Welcome to the Health Workforce Technical Assistance Center's webinar series. This webinar is entitled, A Novel Way to Obtain and Deploy Health Workforce Demand Data, the Washington State Health Workforce Sentinel Network. And it was presented by Sue Skillman and Dan Stubbs on March 20th, 2018. Welcome to the Health Workforce Technical Assistance Center's webinar series. Today's presentation focuses on the Washington State Health Workforce Sentinel Network. And today's presenter is Sue Skillman, the Deputy Director of the University of Washington's Center for Health Workforce Studies. And she is joined by Ben Stubbs, who my understanding is the individual who will be answering all the difficult questions. Now, after the presentation, you may ask questions using the chat panel on the right of your screen. Make sure you send your questions to all panelists to ensure that they have an opportunity to be answered. Also, when the event ends, you'll be directed to a short evaluation survey. So please take a few moments to provide us with your feedback. With that said, I'm going to go ahead and turn the event over to Sue, our primary presenter. Sue?
Thanks, David, and thanks to the Health Workforce Technical Assistance Center for inviting us to present today about Washington's Health Workforce Sentinel Network. We're very eager to share what we've been learning and developing and implementing what we're calling this novel way to obtain health workforce demand data and to make it directly useful to those involved in making decisions about educating, training, and deploying the health workforce. I also want to let you know that we are celebrating the 20th anniversary this year of the University of Washington Center for Health Workforce Studies. And with this webinar, we're presenting our new logo, see down there on the bottom right. So stay tuned for anniversary events for the center throughout the year. The Sentinel Network is a collaboration between the University of Washington Center for Health Workforce Studies, which we also sometimes call CHOOSE, so if I say CHOOSE, that's what we mean, and the Washington State Workforce Training and Education Coordinating Board, or the Workforce Board for short. Our project team at the University of Washington includes myself, Ben Stubbs, who is here with me today, and as David said, he's going to fill in the details and correct me when I get off base. Also, Amy Clark, J.P. Paredes, Davis Patterson from the center, and I should say that Bianca Frogner is the director of the Center for Health Workforce Studies, and she's also lends a hand as needed with the project. At the Workforce Board, Eleni Papadakis is the executive director and Nova Gatman, legislative director, and they've been instrumental in supporting this project, this effort, and really keeping it alive in the state. Our initial funding started in early 2016 with federal support from Washington's STEM grant and later incorporated funding from the state's Medicaid transformation funding, or the commonly known as DSRIP funds. These funds came through the state's healthcare authority, which is the lead organization for the SIM grant and DSRIP, to the Workforce Board, and then to us at the University of Washington. I will add that the Sentinel Network is considered an activity of Washington's Health Workforce Council under the Workforce Board. This is really important in regard to the Sentinel Network, and I'll come back to this later, but the Health Workforce Council is made up of leaders from across many key organizations and people who are instrumental to health workforce development and deployment and policy across the state, such as state departments like the Department of Health, which licenses healthcare professionals, 2-year and 4-year colleges, professional associations like the Medical Association and the Washington Center for Nursing, labor organizations, hospital association, et cetera. Those are the key health workforce stakeholders from all the different settings that somehow or other touch, need, produce the health workforce. Then the beginning of this winter, the Sentinel Network's funding was taken on by the Governor's Office, Governor Inslee, through his Workforce Innovation and Opportunity Act, or WIOA, discretionary funds through the Department of Labor. Those funds will run through June 2019, at which time the Health Workforce Council and us are charged with securing ongoing funding for the Sentinel Network. Okay, so what is the Sentinel Network about? As, of course, everyone on this call knows, we in the country are working towards a transformation of our healthcare system to new ways of paying for and delivering healthcare, from volume to value with the triple and the quadruple aims, as many of you I'm sure are familiar, of improving patient satisfaction, health outcomes, and decreasing or maintaining healthcare costs. The fourth aim adds the goal of improving the work life of healthcare providers, including clinicians and staff. So as transformation takes place, simply maintaining headcount to the supply of and the demand for healthcare workers, like measuring vacancy rates, for example, is not by itself adequate to monitor the changes needed in health workforce. Educators, trainers, employers, policymakers, et cetera, need to have a better understanding of what skills and roles are needed to meet the changing demands of the healthcare industry. And that information needs to be conveyed to and in time for those responsible for health workforce development to be able to respond. The Sentinel Network, therefore, supports efficient and effective health workforce preparation and deployment by identifying emerging signals of health workforce demand, needs, and changes, and then, equally importantly, rapidly disseminating that information to education, training, and policy partners who can take some kind of action based on what the information we're getting from the industry sentinels are saying. So this diagram is an attempt to illustrate this network. So one way I like to describe the Sentinel Network is to call it a data-mediated way to connect healthcare industry employers with the education, training, labor, policy stakeholders involved in developing and deploying the health workforce. This diagram illustrates the overall design. You can see that the middle part is the data hub, and so we academics are tend to be kind of focused on that data part, but what's really important are the arrows. Is that the data don't mean anything if it's not relevant to the industry that's providing it, and then it also gets picked up and used by those who need to react to what the information is saying. So this system takes information about changing health workforce needs of employers. We get some numbers, but also a lot of descriptive comments, and then makes it available to those with interest in acting on signals, and we use the word signals a lot here, of changing health workforce demand. So this is not about collecting survey data for a research study, and that's something that we do have to remind ourselves and others. The goal of the Sentinel Network is to be tracking signals from the healthcare industry of changes in health workforce demand and communicating that with those who need to know about those changes. So how does this work? Well, the data part of the Sentinel Network is hosted on the web. We use Qualtrics survey software to collect information from the industry sentinels from across the broad spectrum of healthcare delivery. We can come back and provide some details of the process of recruiting sentinels later, but simply we open the doors to everyone who, from the healthcare industry who wants to provide information. Being that expansive was a conscious decision, and we can also talk about the pros and cons of that later on. So we open the doors at designated Sentinel information submission times. Our stakeholders and leaders on the Health Workforce Council and others are used to reach out to their colleagues to encourage them to participate. So the Sentinels log into the website to provide their data, where they register and they provide information about what facility types they have, where the workforce is employed, what counties those are located in, and then the registration information populates the subsequent question logic in the Qualtrics system. For each facility type, the Sentinels are prompted to then select the occupations based on standard occupation codes that had recent changes in demand, and then they go on to answer the questions. So we save that registration information, so then repeating Sentinels at the next data collection period don't have to go through and enter all that basic data again, although they can update it. Once registered, the Sentinels are guided through the survey process to respond to these core questions, each of which are structured so that they indicate which occupations are involved and which facility types, and then considerable focus is placed on gaining qualitative responses that add more descriptive details for each question. We worked really, really hard with our advisory group from the Health Workforce Council to keep these questions as short as possible and to minimize the amount of time needed to submit data into the network. It still takes a while, but we've really tried to keep it as short as possible. Of course, keeping it short on the user side requires a lot of work by the developers, and if anyone's interested in some of that, we can go into that also later or at a different time. So this is sort of a short version of the questions, but there's They're all referencing the time period of recently, in the past 3 to 4 months, what occupations have you experienced? Are you experiencing having exceptionally long vacancies, occupations with increased demand, occupations with decreased demand? What new occupations are you employing that you did not previously employ? Are there new roles for existing or incumbent workers? Are there changes in the orientation and onboarding procedures for new employees? And then, and that's kind of getting at to some extent, are people being trained in these occupations with the skills they need to hit the ground running? And then changes in training priorities for incumbent workers. So, and then really importantly, it's not just yes or no questions, it's that, but then once someone has said, yes, we're experiencing that, then we really get into depth around why, how, what, describe some more of what's going on. So I'll say that to date, we've invested most of our work on this first part of the network diagram, getting the Sentinels to the table to provide their changing demand information so we can process and display it through the Sentinel Network dashboard. And here's the timeline that we've been working on. We've completed 4 data collection rounds, each about 4 to 5 months apart. As we launch phase 2, we're reviewing the best timing, among other questions that we're reviewing for going forward, and we expect to collect the next round of data from Sentinels in about June. I realize this is kind of a busy slide, but it's a summary. Actually, the busyness conveys its own information, but it's a summary of the numbers of responses we've had from Sentinels across facility types. Remember, Washington is not a huge state, so the numbers may not look large if you're from New York, but they aren't too bad for here. As I mentioned earlier, we consciously kept the door open to all comers, and you can see that we have larger responses from some types of facilities than others. We believe that the safety net sites and those experiencing the greatest and most difficult demand issues are the ones who are coming to the table in the greatest numbers. In this case, it's the behavioral health facilities, community health centers, and I will say we do have responses from the majority of federally qualified health centers, which we're very happy about, and skilled nursing, and those are listed at the top of this list with the largest numbers. And of course, we have a trusted leader who can make the case for providing information to the network and encourage. When we have a trusted leader who can make the case for providing information to the network and encouraging their participation, it really helps bring the Sentinels to the table to provide their data. With that, I just want to emphasize to anyone who's thinking about building their own Sentinel network system that this is not a passive exercise. There's a lot of work that's needed to build the trust and recognition of the worth of taking the time to come to the table, go to the website, and input an organization's data. We also collect and then disseminate the information back out by geography. The state's SIM grant created 9 health planning regions across the state called Accountable Communities of Health, or ACHs. While we collect data from these Sentinels by county, occupations in demand by county, we roll the county-level data up into the 9 ACHs for purposes of reporting. This is both because, for policy reasons, there's a lot going on in the state with the ACHs, but also by the time you get down to a lot of these counties, the confidentiality goes away. So the ACHs work for these purposes. We're pleased that we have data for from all of the ACHs in the state, and as you can see from this graph, or you don't have to see it in too much detail, but the graph from our dashboard shows that we have good variety of facility types reporting in most ACHs. You can tell that because the colors represent the different facility types, and then the bar heights reflect the number of different facilities for which data was reported by each geographic region. So this is just a couple of the time periods for which we've collected the data, but the multicolorness indicates lots of reporting across facility types. So I'm now going to describe an example of why data such as that provided by the Sentinel Network is useful using the example of medical assistance. Traditional workforce planning data come from sources such as, or typical, I should say, maybe traditional, come from sources such as the Federal Integrated Post-Secondary Education Data System, or IPEDS, from the National Center for Education Statistics, And from there, you can obtain counts of graduations and program completions from all levels of post-secondary education programs. Similarly, using data from the Department of Labor, there are estimates of the number of employed persons, or FTEs, the number of job vacancies by industry and setting and occupation type, et cetera. So these are really, really useful data, and we all use them a lot. But they're not sufficient to answer all of the workforce planning questions, especially in a time of changing industry workforce needs, and so that's where the FTE counts or head counts don't quite provide enough information. So this example on this slide is referencing the 2016 Health Workforce Council annual report that compared the IPEDS data on medical assistants in Washington, the number of completions in the state that year, 2,821, to the job vacancies reported by the Bureau of Labor Statistics. At first blush, one might get the idea that filling MA jobs in Washington state is not a problem for employers. But that was not what we were hearing when we were in conversations with employers. So I'm going to walk us through findings from the employer Sentinels to see what they indicated through the Sentinel Network about demand for medical assistance. So this is a screenshot of the homepage of the Sentinel Network dashboard. It provides background, finding summaries, findings by facility type, and findings by geographic region, or ACH, in the state. So I'm going to simulate clicking on the far right box with the kind of purplish pink one, which takes you to the findings page. So here is the screenshot of that page, and you can see that the large blue buttons represent the different questions asked of the Sentinels when they submit their data. So now I will simulate that I'm clicking on the vacancies button. And here you can see the full question that was asked of Sentinels at the top of the page. So the vacancies question is, recently, in the past 3 to 4 months, has your facility type experienced exceptionally long vacancies for any open position? If yes, for which occupations, and what are possible reasons why? You can see there's a drop-down menu to select one or more facility types. So in this example, I've selected federally qualified health center or community clinic providing care free or on a sliding scale, which I'll just kind of call the community health centers. Note, you can also select which data collection period you want to view, that's the next box to the right, and how many occupations to display at once. So for the community health centers responding to the question about exceptionally long vacancies, the results in the first section of the display show findings for fall 2017. You can see, and I've underlined in red, that community health centers responding to this question last fall indicated MAs were among the top occupations for which they'd experienced exceptionally long vacancies. One note, because this is not a representative survey of all employers, and we're gathering data from volunteer employee Sentinels, we're looking for signals of workforce demand change, not absolute demand numbers. Now, if we were to get 80 to 90 to 100% or whatever percent you want of all those facilities in the state to respond, we could start treating this more like a representative survey. But we acknowledged and intended that we were looking for those Sentinels for the signals. So one of the issues is that how to interpret these bars can be a little bit not as intuitive as some people want. So we've avoided putting percentages on the ends of the bars. The bars should be seen more as rankings as a result. In other words, last fall, community health centers most often mentioned that MAs were among occupations with long vacancies, and they also mentioned dental assistants, RNs, and physicians at the top of their lists. That said, if you hover your cursor over the bar, you do get the numbers that correspond to that bar, which I will simulate now. So in this case, you see the box that pops up when I hover over the MA bar says, for Sentinels representing an FQHC, blah, 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 8 out of 23, or 35%, reported the occupation medical assistant as experiencing exceptionally long vacancies in the past 3 to 4 months. So each one of these bars will give you the sentence as to how to interpret that bar. And I will pause here and give a lot of credit to Ben and Amy for doing all the programming needed to make these things pop up and put in the occupation name and put in the numbers and, you know, all this Tableau. And I may not have mentioned this up front. We did use Tableau for the display, and we're continuing to tweak that as we progress. But anyway, we're trying to make it as easy on the user as possible and provide some of this interpretation information. But I think as important and valuable from our Sentinel network is the function that comes from actually clicking on that bar, not just looking at the length of the bar, which is how we view what respondents said about these occupations. So clicking on the individual bar brings up a new set of responses to the right, which both summarize and provide the exact comments from respondents. So in this case, by clicking on the MA bar at the top left, the dashboard shows a summary of the different comments by groupings, which are groupings that we've assigned to them. And if you hover over one of the cells in those comment bars, you can see the exact comment. In this example, I've hovered over one of the comment cells next to not enough qualified applicants, and the comment is that was provided by the Sentinel is high expectations on experience. In other words, I think they're saying the applicants don't have as much experience as the employer expects. So other comments in that category include things like high turnover, not receiving enough candidates, county demand higher than educational institution provides, et cetera. So from last fall, other comments related to MA vacancies, which you can see if you hover over some of the other comment cells, are traffic and cost of living in the areas that vacancies exist, and low compensation and benefits, and we struggle because we recruit Spanish-speaking MAs, et cetera. So it gives you that depth of understanding of what the employer's issues are about trying to, why those vacancies are existing. So the findings, as you can see, are now painting a more robust picture of the issues employers are having with filling demand for medical assistance. Findings can also be reviewed by geographic region. This is a screenshot, although I have to say this is an old slide, and so the screenshots don't have the percentages. They look a little different now when you look on the website. But anyway, you can just see that by ACH, by geographic region, MAs are showing up somewhere in the rankings for each of those. So it's not just an isolated issue in the state, but to some extent or another, MAs are having exceptionally long vacancies for employers across the state. I'll share a few other summaries for MAs. Among facilities reporting occupations having exceptionally long vacancies, again, I'm focusing on that one question here. Across all data collection rounds, MAs were among the top occupations with exceptionally long vacancies in community health clinics, other primary care clinics, specialty medical clinics, and acute care hospitals. And then again, by geography, MAs were among occupations with exceptionally long vacancies in most, if not all, of the geographic regions of the state. There are other questions about changes in onboarding and training priorities by occupation and setting of the Sentinel employers. Here are some examples of some of the comments about medical assistance, such as EHR training and more EHR skills are needed for MAs, knowledge of quality data tracking. We need more onboarding curriculum tailored to focus on EHR competency, so quite a bit on EHR and HIT. Other skills are listed here, gathering sexual orientation, gender identity, demographics, customer service training, et cetera. And the comments from Sentinels also have suggested solutions to some of their workforce issues. For example, with regard to medical assistance, some of the comments have said things like, we have an MA trainer that they're paired with to deal with the onboarding issue. We also have an MA apprenticeship program to grow our own, and I will say Washington has quite a bit going on with MA apprenticeships right now. They developed a residency program for MAs and some comments about partnering with local colleges. So again, for this data-mediated network to be fully successful, the information from the industry sentinels must be connected with the education, training, and policy stakeholders for it to be useful. While we've made a lot of great progress in this area, in phase 2, we really hope to make that stronger, to build and strengthen that part of the network. So with regard to medical assistance, what did the Sentinel Network tell us about IPED? Tell us that the IPEDS and BLS data couldn't? Well, our employer sentinels were pretty clear that there's not a statewide surplus of MAs that meet the hiring needs of the employers. with these findings, we're encouraging and helping our stakeholders to investigate this further, things like exploring if there's a drop-off in between program completion and MA certification. Are the skills and preparedness, is there variability in the completers from different education programs? We know from a survey we just finished that about 45% of MAs in the state went to for-profit schools, about 55% went to not-for-profit. Is there a difference there? Possibly need more remote distance education, more apprenticeships, et cetera. So these are the questions that I think are the actions, what's needed to address some of the issues. Okay, just really quickly, I'm going to highlight some of the other findings that we will summarize, but you can explore more on the Sentinel Network website dashboard. With regard to registered nurses, we've been finding that RNs are the top occupation with exceptionally long vacancies reported in small hospitals and home health care. By geography, RNs were the top-ranked occupation with exceptional vacancies at different levels at different times, but still they're showing up in most all of the geographic regions as having hiring difficulties. Reasons for long vacancies, these are just some of the examples, but new grads want that acute care wage and experience. Workforce doesn't meet demand. These are in the hospitals. Difficulty recruiting in rural areas. The rural issues come up over and over again. A lack of experienced specialty nurses who want to come to a rural area. Night shifts are difficult. Too many positions. Traveling companies scoop up what's out there and pay them too much or more than we can compete with. Lots of comments in the long-term care arena. Skilled nursing facilities are now required to have RNs on staff 24/7. That's really hurting the skilled nursing facilities, or really making it difficult for them to have enough RNs. Nursing homes aren't as attractive to potential RN candidates. Regional information, a local hospital opened over 100 RN positions, severe impact on the community. That's the kind of thing that we can take into account in planning and saying, well, is this a one-time thing? Is this a trend? What are the longer-term implications of that? So examples of training and onboarding needs from the Sentinels with regard to registered nurses. You can read through some of these examples, but again, the EHR and HIT skills, more of those are needed, more customer service skills, lots of comments about behavioral health training, dementia knowledge, that came up numerous places, et cetera. So what are some of the takeaways to date from the Sentinel Network with regard to registered nurses? Well, RNs are in high demand across healthcare sectors, healthcare facility types. EHR, HIT-related skills are among ongoing training needs. Experience remains important to employers, and nurses tend to follow better salaries, shockingly. So what are the next steps? We need to engage more discussion with stakeholders about what this means and what possible responses should be. And those could include things like, does it make the most sense to turn up the education spigot, as I like to call it? Do you just produce more at the education institutions, as if that were an easy thing to do? Or should there be more emphasis on retention and enhancing the skills and roles of incumbent RNs, and/or some combination of both? So on a couple other types of occupations, we had a lot of information from our Sentinels on behavioral health occupations. As I'll point out in a later slide, we used Sentinel Network data in our recently completed study with the Workforce Board assessing Washington's behavioral health workforce. So examples of some of the kinds of rich input we had from Sentinels were that around chemical dependency professionals and substance abuse and behavioral disorder counselors. I'm sorry, those are behavioral health occupations. That by facility type, the combined occupations of CDPs and substance abuse and behavioral disorder counselors were the top occupation with long vacancies reported in large hospitals, behavioral health clinics, and psychiatric and substance abuse hospitals. Also important at FQHCs. Reasons included low wages and difficult working conditions, increased client acuity, lack of qualified candidates. Integration with managed care means many new positions. This gets into the weeds around what CDPs can do and and the need for dual credentialing of people with both substance abuse treatment and other behavioral health treatment skills. And so people with those dual licensures then get scooped up and hired in other settings, leaving some vacancies. In the substance use arena, long licensing process was mentioned, and then of course supervision requirements before practice in the behavioral health arena is very intensive and lengthy process. So these comments are, these types of comments are addressed more fully in our behavioral health workforce assessment report, which there's a URL for in a later slide. We have done some internal evaluation led by Davis Patterson here in our center. Inquiries and feedback were gathered from users who used the system in 2016 and 17. We both reached out directly to them and invited them to fill out a questionnaire online, another Qualtrics questionnaire. We also posted a please provide your comments box on our website. And we had a reasonable number of responses across a number of different kinds of organizations. And in general, the responses were positive, but they clearly point to our need to strengthen that second half of our network diagram, connecting the Sentinel Network information with the stakeholders who can act on those findings. These graphs just show, there's a couple more in our evaluation report, but just kind of show that there's general uptake with use of the information, but clearly we can strengthen how those data get used. And so this evaluation, as much as we love to have every bar out there at 98%, this was a very useful for our future planning, these responses from our evaluation. So in summary, here are a few points about what is valuable from the Sentinel Network approach to obtaining health workforce demand information, especially as our healthcare environment is rapidly changing. We think that it provides rapid turnaround signals of workforce demand changes, and it's relatively inexpensive, provides much more of the how and why behind these signals than you can get from typical workforce numeric data. It identifies skills needed, highlights local conditions that may make hiring difficult, and engages the full network of stakeholders needed to identify and solve workforce problems. As I mentioned, the Sentinel Network findings have been used in our assessment of the state's behavioral health workforce, and that report title and URL is on this slide. In addition, the results have been reported in depth by the Washington Health Workforce Council, our partner in this, and you can see some more of those detailed findings in that report. Also, the accountable communities of health are exploring using Sentinel Network data in monitoring health workforce demand in the state's healthcare transformation regions. Our state community college health program deans and directors group has been engaged in interpreting findings, and we hope to engage them even more in phase 2. HR directors groups have been very interested in the findings and have found that our comments back from them have been rewarding, in that there's a lot of, yes, this is what we've been trying to tell people. So that's useful. And it's also being considered for use in other states. And Marcia Proto, if you're on this call, this is a shout out to you. She's been working on figuring out how to adapt this for Connecticut. So phase 2 has just begun, and we're now taking the time to work with the Health Workforce Council and others to improve the Sentinel Network process and its effectiveness. Well, among options that we're considering include coming up with improved and additional formats to display the findings, possibly less frequent data collection. We're thinking that maybe 6 months is every 6 months, twice a year, rather than the 3 times a year we've been working on. We want to work, as I've mentioned, on methods for greater engagement with the response panel and stakeholders to get more interpretation and dissemination of findings, engagement with those data. More options for user interaction. We would be open to possible customizable modules. So in other words, if one type of hospitals or long-term care wants to go in more in depth, that is entirely doable. It's sort of a resource question, but that's something we can entertain. And then, of course, the long-term sustainability plan is very important. So that's been a lot of material, but I want to, again, thank our team and the Workforce Board and everyone for all of the work, and plus all of the Sentinels who've provided all this information. So I think we will turn back to David to ask questions and how we best respond.
Okay, thank you, Sue. That was very informative. I know personally speaking, I've always been a big fan of your Sentinel network. And we do have a few questions for you. The first question is, are the Sentinels paid to input workforce data? And really, as kind of a follow-up, how did you go about recruiting participants?
No, no one's paid to provide data. Recruitment it's been a lot of work, and we've tried different things. Really, the most effective recruitment tool we found is to engage the trusted leaders in each sector to reach out and make the case and encourage their partners and their constituents to come to the table. We have compiled many lists of addresses of directors and HR directors and groups and things, and sent out lots and lots of direct email contacts saying, the door is open, come submit your data to the network. Contacted lots of professional organization heads, and they put notices in newsletters, they send encouragement emails to constituents, et cetera. The Health Workforce Council members have contacted their constituents. We have personally made lots of presentations on the purpose and findings, et cetera. But I do think that, and going forward, what we're going to emphasize is to engage those leaders across the industry and across education and training, and really make this all the more their case, and have them make the case as to why this is important and how those who submit data benefit from what happens after they submit the data.
Thank you, Sue. How do you determine who from each institution should report to the Sentinel network? That is, it seems like it might require entries from many individuals within an organization to get demand for different professions, i.e. nursing data might be from CNCs. Other data might need to be provided by HR, et cetera.
Yeah, when we ruminated about that a lot, and we finally decided that given the kinds of data we were focusing on, we were going to leave it to the organization. So and we know that some organizations have combined the input from different folks, and maybe others haven't. But again, since we're not this is not a heavily quantitative assessment, we're kind of open to all comers and all comments. And to do more and to be restrictive would probably take more resources than, and I'm not sure that the juice would be worth the squeeze for the kind of information, the rapid turnaround, the signals, again, of health workforce demand change that we're trying to get to with the network.
All right, thank you, Sue. And let me find another question here for you. Okay, do you find the SOC occupation codes adequate to capture things like demand for specific types of RN, for instance, ICU versus prenatal, et cetera?
Yeah, that's been an ongoing dilemma. That is the problem when, or the issue of upfront, well, I should say that you can't, it's hard to be all things for all people, and that is one of the things we're struggling with in phase 2. The Health Workforce Council and the Workforce Board really did not want us to narrow who we invited to be part of the Sentinel network. In other words, they wanted the whole healthcare industry to be able to step up. So that could be oral health, dental folks, behavioral health, hospitals, clinics, et cetera. So designing an instrument or a set of questions and figuring out which occupation codes to use to not be too onerous to the organization submitting the data, but be meaningful on the other end, has been it's a balance. So I have to say that the SOC codes we've used, we look at registered nurses, but we don't have in our registration or in our system a breakdown of ICU versus med-surg versus whatever. We don't go into specialty. Same thing with physicians. Therefore, we lose some information that we hope to pick up in the comments. So a hospital respondent may say, RNs have had exceptionally long vacancies, and in the comments we may pick up, and it's the ICU nurses, experienced ICU nurses or something. But that's a kind of a passive approach. So that is an area where I think our solution to that, and we're exploring that in phase 2, is that module approach. So if there's enough interest from, let's just say, hospitals, to have an added module that if you say you are a hospital, for example, then you, in filling out the data, then you go down a different path to get more in depth on some of the staffing that are specifically related to hospitals. That's something that we will entertain doing in phase 2, if there's sufficient demand for that. Anything else, Ben, with response to that question? So, no, they are not, the SOC codes are not by themselves adequate, but again, it's that tension between trying to keep it short and frequent data input to get the signals of workforce demand changes versus having a whole lot of detail to understand every single issue. But I think that's one of the reasons we don't have as many large hospitals at the table.
All right, thank you. Understanding that each state is different, are you able to throw out a ballpark estimate of what it would cost to start up a Sentinel network in another state in terms of cost, FTEs, skill sets, et cetera?
That depends. You know, we've been doing this for $80,000 to $100,000 a year, and then once it's up and running, you know, it can be less. So in the scheme of things, that's not too bad. Your startup costs are going to be more expensive, but I should say that does not reflect the cost of getting the Sentinels to the table. We rely a huge amount on the collective will to make this happen by the stakeholders around the state, the Health Workforce Council members, the heads of the home care agencies, the Hospital Association, the WACMAC, the Washington Association of Community and Migrant Health Centers, has been outstanding in recruiting from their groups. The Behavioral Health Organization group has been outstanding. So maintaining that data hub has been really where the costs for us have gone. And that could be depending on if you already have someone with survey experience or Tableau experience. You know, I'd say it's between $50,000 and $100,000 a year, at least by our metrics.
Okay, and really kind of a similar question. Are you willing to work with other states? And is there an opportunity for ACHs to work with the Sentinel Network to survey their regional partners?
Well, everything's possible. It's a resource and timing issue. So we would love to see this picked up and used and made more usable and applied elsewhere. I mean, that's the whole point. We as researchers, we're not necessarily interested in the business of doing exactly this forever, but it seemed like the time was right to find a way to get beyond just those vacancy numbers and completion rates data to get kind of behind the scenes and understand and help to develop the programs and the policy to address these changing health workforce demand needs. So the broad answer is yes, and of course the devil's in the details, but we're more than happy to talk with folks.
Thank you, Sue. Are there efforts made to ensure that large employers join the network?
Oh, absolutely. Well, are there efforts? Well, we've had a lot of large employers, if you mean like large healthcare employers. We have a number. I can't name who they are because we do work to maintain confidentiality, but we've had some of the big players in Washington involved and being among the leadership. So right now, again, we're trying to be all things to all comers, which could be one of our weaknesses. So, but you know, to introduce this system, that was our intention, was to see what happened when we just opened the doors widely.
Okay, and you kind of hit on this already, but could perhaps you talk a little bit more in detail about the types of strategies you use to ensure continued participation in your study?
Well, I think the best strategy is to be useful, to collect the information and show it in a way that then it gets used in that feedback loop. Those rest of those arrows on that diagram link back to the users that, hey, we took the time to insert all this information, and you know what, it paid up. They got the message out there, and now somebody's actually working on more EHR, HIT skills for medical assistants or something. I mean, that's the whole goal here. It's a data-mediated communication device. This is not hypothesis testing research. This is trying to link up all those players, and it's a very varied world against the education and training systems and the healthcare delivery systems, and ranging, people who employ nurses from all these different environments. So we're trying to get the message out. I don't think that many of the messages are brand new and new news to people, but it's a way to, some of them are, but it's a way to combine the voices of the employers, of the healthcare industry in a way that strengthens the message and we can reference the message in one place and then work with groups like our Health Workforce Council, our Workforce Board, the Governor's Office, et cetera, to then try to say, hey, we're hearing there's an issue out there, it's documented in this way, what are we doing to work on it?
Okay, and here's a little bit more technical question. You mentioned during the presentation that for your dashboard you use Tableau, and you also use Qualtrics for the survey component. With that in mind, in your view, what kind of expertise with Tableau would be needed to build the Sentinel reporting system in other states? Is special programming needed? Besides Qualtrics and Tableau, are you using any other types of special software for this project?
This is Ben. I could handle that question. I will say that one of the reasons we went with Tableau is that we were interested in providing this information in an interactive format. So we wanted to put the information on a website and allow users to explore it on their own, and but also allow them to find all of the rich qualitative information that we've been gathering. So if it depends on how you're going to use and present the data. Since that was our goal, that's why we went that route. If there is a bit of a learning curve with Tableau, but I think it's not as steep as some of the other software applications that may be available for that type of interactive information. We just went with Qualtrics because it allowed a little bit more flexibility and control with the dip patterns and the structure we wanted to put around these questions, but it could be done with a much simpler approach.
And we've been looking at, in fact, using RedCap as well, and we're open to other ideas. So and I should say the University of Washington also is great, supports Tableau, internal server, we can get to it for, anyway, there's a lot of reasons that our support from the university caused us to choose some of the software you're using, but I'm sure it's amenable to other kinds of software.
Yeah, but if you'll notice in the presentation that Sue did today, a lot of the information we presented was really pulling out comments, kind of, I guess, quote unquote, traditional qualitative analysis of the data. So based on that, I would say that it isn't necessary exactly to use Tableau or a specific, software to get valuable information from this type of data and this type of approach.
Good point.
Okay, and really kind of a follow-up question in regards to Tableau. I've heard that it's not so simple to update Tableau visualizations with new data. Do you find that you have to rebuild the interface with each update? Have you found a way to automate the updates?
Yeah, that's been a struggle. When we first started this, I was new to Tableau and initially set it up in maybe not the best way for this type of approach where we're doing updates every 3 to 4 months. But since then, I've rebuilt the guts, I guess, of the visualizations to make it a little bit easier to do that. I haven't gotten into the really advanced features of Tableau that can allow a live connection to a data source. That is apparently possible. What I end up doing is basically creating a new Excel data source each time we need to update the data, and then that's become a little bit more smooth as now we've gone through 4 iterations of this. But that is something that does take advanced planning and thinking of how to make it easier on yourself if you're going to be doing these updates on a regular basis. But I have found ways that Tableau has allowed me to do that relatively simply and in a more easy manner than the way I initially set it up.
Thank you, Ben. Sue, I believe this one's for you again, or maybe y'all both have some thoughts on it. Do you find that users interpret the Sentinel Network findings appropriately?
Well, I mean, that's been a concern because of kind of how different Sentinel Network is and what we're trying to do with the signaling, as opposed to, the classic representative surveys. So, as I pointed out in my presentation, wherever possible, we try to mentor people in the interpretation by spelling out sentences on how you would use the data and use the findings. Certainly the comments are straightforward, but when you look at those bars of responses and things, I think it's important to be careful to guide people and to quickly move them to the descriptive information and to not be as obsessed with or as focused on the lengths of the bars, so to speak. The lengths of the bars say, hey, that's signaling there's a good-sized number of folks saying something here, what are they saying? And try and get more to the what are they saying, what are the issues.
Okay, thank you, Sue. And what do you do about people who want a percentage or a shortest number relative to a rank, which you try to present them with?
We sent them elsewhere. I mean, this just does not do this. The Sentinel Network is about the network. It's about being the data-mediated hub to provide a voice from the healthcare industry and those employers who have healthcare demand issues with the stakeholders who should be engaged in helping to solve those problems. And I would say that if they had an exact shortage number, that would not help them solve the problems. We need that rich information about roles and changing roles and skills, et cetera, in order to try and figure out, is this a spigot issue? Does this mean we just turn up more at the spigot of the education institutions? Or is this something about we need more training resources for incumbent workforce? We need more career pathways. It's impossible to get people at these low wages to work in the Seattle area because nobody can afford to work here. I mean, this is the kind of messaging that's coming through here that, just like that MA example I used, if you just look at the numbers and look at the vacancy rates, it looks like there shouldn't be a problem, but that's not what we hear from the employers.
Okay, Sue. Well, I'm not really seeing any more questions from the audience at this point in time, and we are kind of getting close to the hour. So with that said, do you have any final thoughts you'd like to share?
No, this has been a great work for us, and I really, really want to reach out and thank Eleni Papadakis and Nova Gatman at the Workforce Board, as well as the Governor's Office and our colleagues at the Healthcare Authority in Washington and everybody else who's helped work to build this system. We're moving into phase 2. We're going to make it much stronger and take lessons from what we've learned to date, but it's exciting. It's a different thing for us to be working on, and we're excited to move forward and really do meaningful work in addressing the health workforce development needs of the state. And it's really neat to be in a state that's so activated to work on these issues together. It's great.
All right. Well, thank you, Sue, and thank you, Ben, and of course, thank you in the audience for attending today. Just to let you know, we will be posting our slides shortly to our website. So if you want to download them, check back very quickly at healthworkforceta.org. We hope to see you again in the future. Thank you, and have a good day.